Great. All right, we'll try it again. Good afternoon, everybody, and welcome to our monthly Mass General Geriatric Medicine Town Hall. We have a very interesting topic and presenters today who have graciously volunteered their time. I'm really looking forward to their content. And I'm glad you took time out of your day. I agree with Judy. It is an absolutely beautiful fall day here in New England. And your sacrifice of that to come here is noted and much appreciated. So with that, I'm going to turn you over to our moderator, Susan Edgman-Levitan.
Thank you, Dr. Russell. My name is Susan Edgman-Levitan, and I'm the director of the Stokel Center for Primary Care Innovation at Mass General, and I'm going to be your moderator. So before we get started, I just want to share a few housekeeping rules. Everyone on the call, except for the speakers, are muted to eliminate any background noise. To view the speaker on your full screen, you just click on the full screen in the upper right corner, or if you want to see the speaker along with all of the other participants on the call, you click on the gallery view, also in that upper right corner. If your picture becomes jumpy or gets out of sync, or even if you're having trouble hearing the sound, click the stop video icon in the lower left corner, and that will help speed up your internet connection. We will have time today for questions, and we really encourage you to ask questions. And to do that, please use the chat feature, which is right in the center in the bottom ribbon across your Zoom screen. And please ask questions, and I will keep track of all those questions and we'll pose them to the various speakers after we finish the formal presentations. I also just want to remind everybody that everybody on this Zoom town hall can see what's written in the chat. So please don't use that to ask about a personal medical question. Please don't show anything in your picture that's personal related to medical questions or issues, because again, everyone can see that. But if you do have a medical question, we really want to encourage you to reach out to your doctor. So we'll do our best to answer all the questions, and if need be, we may send out some more information after the call. So with that, I want to introduce our speakers today, and I'm going to actually share a little bit more in my introductions than I typically do. So we're going to hear from Dr. Leland Hull, who is a general internist at Mass General and a clinician investigator whose research focuses on evaluating the barriers to the uptake of evidence-based preventive genetic testing and the role of primary care providers in facilitating access to genetics care. We're also going to hear from Ms. Renee Pelletier, who is a certified genetic counselor in the MGH Center for Genomic Medicine with a background in cancer genetics. She is interested in research around the equitable implementation of clinical genomics and additionally serves on the Public Policy Committee for the National Society of Genetic Counselors. And then we're also going to be hearing from Ms. Sindura Paluru, who is a nurse practitioner in our geriatric medicine practice, and also Haley Shanker Redstone, who is also a nurse practitioner in our geriatric practice. And they're going to be sharing with you updates about what's going on in geriatric medicine. So with that, I'm going to turn this over to Dr. Hall, and welcome to everyone.
All right. Is my screen share okay?
Yes.
All right. Well, thank you so much for having us today. And thank you for the introduction. Not advancing. Okay. We just wanted to start off by stating that we have no conflicts of interest to disclose, and also to make a clarification about our presentation. And so in this presentation, we will focus on genetic testing for disease risk for patients who do not currently have symptoms, and so asymptomatic patients. We are not going to focus on the diagnosis of disease for patients with symptoms. This is usually the purview of our subspecialty colleagues in many cases. And so here you can see our learning objectives for today. What we'll start off with is an overview of genetic testing for health risks with Ms. Pelletier.
All right. So we're just this may be kind of a refresher for some folks, but we just wanted to make sure that we're all on the same page about how our genetic code informs our genetic health risks. So just to get started, our genetic code provides really the instructions. It's like our instructions manual for our body's functions. And our genetic code is inherited from our parents. So you'll see on the right here, one common example of this is the way that our blood type is inherited from our parents, leading to a variety of results for children of those parents. Next slide. But our genetic code is actually mostly identical between all people. So it's about 99.5%, actually more than that, similar between all people. However, next slide. Small differences in our genetic code make us unique. So things that we might think about are our hair color, our eye color, our height. But there are specific health problems that can be associated with small differences in our genetic code. So our genetic code can sometimes influence our risks to develop disease, and Dr. Hull will go into some of these examples. And some traits are actually influenced by both genes and environment. So one of the things that we sometimes say is our DNA is not our destiny. There are ways that we can protect ourselves from risks that we inherit from our families, and there are ways that we can influence our environment to keep us as healthy as possible. So our genetic testing is a way that we can look into that genetic code and provide patients with information about their health and different traits that they might inherit from their families. So we wanted to give a couple examples of how we might use genetic testing in the clinic. So on the left, you'll see genetic testing for reproductive planning is a very common use of genetic testing. So this might be providing testing for individuals who might be considering starting a family to see if they're at risk for passing on any genetic conditions to any future children. This also can be done during pregnancy or even after pregnancy to follow traits that might be happening in a family. That second category right in the middle is genetic testing for various risks for disease. So you'll see this image above. There are certain conditions that we can actually test if people have a predisposition for a buildup of plaque in our arteries, which can be a risk factor for heart attack. There are lots of different other diseases that we can actually do genetic testing for to assess these risks. And Dr. Hull will go into more of this. And an emerging topic that you may hear about related to genetic testing is actually testing for medication response. So this might be looking at our genetic code to see if we're going on a new drug, if we might need a specific dose of that drug or avoid that drug altogether to avoid any adverse outcomes. I'm going to pass it on to Dr. Hull now.
Thanks. And so next we're going to talk a little bit about an overview of current guidelines for genetic testing for health risks. And based on these guidelines, who should consider genetic testing? And again, I'm going to note that I'm going to focus on patients who don't have symptoms of disease and are interested in their risk of developing a disease. So there's been a lot of talk about using genetic testing to try to identify people at increased risk of a disease. For example, to identify people at increased risk of developing certain cancers. So like Ms. Pelletier said, hereditary cancers, a predisposition to those, heart disease, or dementia. When thinking about using genetic testing in this way, we have to consider a few things. First of all, is the disease serious? So for example, is it something where we really would want to know about our risk, like a cancer? Two, we want to know that the genetic testing would help us to potentially identify and detect the disease early, or even before symptoms develop, to reduce the actual risk of getting ill or dying from the disease. And then three, we also consider whether there's a large enough proportion of the population that's at risk for a disease where screening is worthwhile. And so these premises for general screening also apply to genetic testing for health risks. So when considering whether or not a person should receive genetic testing for a disease risk, such as the risk of developing Alzheimer's disease, they may consider these factors. Additionally, organizations that develop clinical guidelines about who and when to screen for diseases will consider these principles. And for many genetic tests designed to determine if someone is at risk of disease, we do find that the evidence to weigh the risks versus benefits are really is really in development. And so for only a few kind of genetic tests for health risks do we have more robust evidence to say whether or not to use them. So there are some conditions where expert groups have synthesized existing evidence about the risks and benefits of genetic testing to assess health risks. And they've issued recommendations to support clinical genetic testing for certain disease risks. These groups include the US Services Preventive Task Force and also the CDC's Public Health Genomics Group. So probably the best known case of this is with screening for the BRCA1 and BRCA2 mutations. So BRCA1 and BRCA2 are genes that, if they have changes, disease-related changes or mutations, they can predispose you to developing certain types of cancers like breast, ovarian, prostate, or certain cancers of the gut like pancreatic cancer. About 3% of breast cancers and 10% of ovarian cancers result from inherited mutations of the BRCA1 and BRCA2 genes, and high-profile cases of celebrities with BRCA mutations, like Angelina Jolie, have led to increased awareness about these genes. Individuals who are found to have a mutation in these genes can consider measures such as enhanced screening for cancers, or ways to reduce their risk through use of medications or surgery to reduce their cancer risk. And so BRCA1 and BRCA2 are really the only case currently where the US Preventive Task Force, which is an independent panel of national experts in prevention and evidence-based medicine, have issued a guideline supporting primary care physicians sending patients with a family history of cancers associated with these mutations for potential genetic counseling and/or genetic testing. So the US Preventive Task Force issues a letter grade of A or B to any recommendation that a service be offered routinely. And task force recommendations really, and especially in primary care, are the kind of the highest tier of these are services that we should really make available to our patients. So in 2019, the US Preventive Task Force updated their recommendations regarding BRCA testing, and they currently recommend that, they say here, the net benefit of risk assessment for increased risk of BRCA1 and 2 mutations is that you should undergo a risk assessment if you have a family or personal history of cancers associated with these mutations. But I do want to note that the task force limits their recommendations to those who have a family or personal history of cancer. So right now, for people who don't have a family or personal history, they're not recommending routinely that those people be screened for these mutations. There are additional conditions that have been recognized as potentially impacting patient care. So the CDC has identified 3 conditions that can be passed down through families, where genetic and genomic technologies could have an impact on public health. So they call these the CDC Tier 1 conditions. And they estimate that nearly 2 million people in the United States are at increased risk for these diseases because of genetic mutations. So these 3 conditions are the hereditary breast and ovarian cancer syndrome, which is basically the changes in the BRCA1 and 2 mutations that we just spoke about. The Lynch syndrome, which is a disease associated with increased risk for colon cancers, cancers of the uterine lining, ovarian cancers, and some other cancers. And then familial high cholesterol. And so you may have noticed that high cholesterol can run in families, but familial hypercholesterolemia is a specific type of high cholesterol associated with specific genes where the mutations lead to very high levels of cholesterol from a very early age. So these are some of the conditions where there's growing evidence to support kind of screening for risk. But then I mentioned that whenever we're taking into account whether we should do genetic testing, we also have to think about whether the benefits outweigh the risks. So what are some of the risks of genetic testing? So one potential risk or consideration is that the results, there's been a lot of concern that results may provoke worry and anxiety. So let's take, for example, the controversy about genetic testing for Alzheimer's disease risk. So mutations in the ApoE gene have been associated with an increased risk of Alzheimer's disease, but they don't preordain someone. So somebody with these mutations doesn't necessarily develop Alzheimer's disease. And the risk depends on the number of copies of the mutation in this gene, their age, their ethnicity, their gender. And so many thought, okay, if we did genetic testing of people without Alzheimer's disease, this has ended up being controversial and is generally actually discouraged because there's unclear what we would call clinical utility of this testing. So first, how would we counsel people to avoid if we determined that they might be at increased risk, but not necessarily going to develop the disease, there's a lack of preventive options beyond what we would recommend for everyone to maintain their brain health, like cardiovascular, exercise, some brain building activities, and eating a good diet, controlling your blood sugar and controlling your blood pressure. And so we recommend those things across the board, and that would not change based upon this type of testing. There were also considerations of whether testing for Alzheimer's risk could provoke a lot of anxiety and worry. There was a study published in 2009 where they did take patients who had a parent who had been diagnosed with Alzheimer's, and they offered testing for this ApoE gene to the participants, and they basically randomized them, so divided where half of them got the results and half of them didn't. And they didn't find that the people who got their test results suffered a lot of what we would call psychological harm or emotional distress. But the long-term impact of this type of testing is not really known at this point. So at this point, at least for the ApoE gene, testing for Alzheimer's risk is not routinely done. Another consideration around genetic testing and a potential risk is that you'll end up with unclear or uncertain test results. And so DNA sequencing, or reading each letter in our genetic code and comparing this code to a reference, or what basically is used to identify variants or changes in the genetic code. However, not all changes have been classified as either benign or non-disease causing versus pathogenic, which would be potentially disease causing or putting someone at disease risk. And there are plenty of test results that return in this middle bucket. And these are called variants of uncertain significance. And so receiving these types of test results could lead to uncertainty about what the test results mean for patients and providers. Fortunately, there are systems in place and being built as we learn more and more about different changes in the genetic code to reclassify these variants of uncertain significance as either not disease causing or benign or pathogenic. But this is an area of uncertainty associated with genetic testing. Another consideration is privacy. There are concerns about if having a genetic test result could be used against a patient. For example, if it showed an increased risk of a cancer. So fortunately, the Genetic Information Non-Discrimination Act was passed in 2008 and specifies that health insurers and employers cannot use genetic information in decisions about insurance eligibility, coverage, and employment decisions. However, this law does not apply to disability, long-term care, or life insurance, which may be a consideration for patients. And then there's always the consideration that with genetic testing, there could be unexpected findings. So for example, people doing genetic testing for ancestry may learn things about unexpected different parents in their family or conditions that they didn't know that they were predisposed to. And so it's important to have an understanding about what a test might reveal before getting genetic testing. Finally, laboratory quality is a consideration. For example, with direct-to-consumer genetic tests, such as that you may have heard of, just because a genetic test is approved doesn't mean it's perfect. And so there are different bodies like the Clinical Laboratory Improvement Amendments and the College of American Pathologists, as well as the FDA, that help to do some regulation of genetic testing quality measures. So I'm going to turn things back over to Renee, who will talk a little bit about meeting with a genetic counselor.
All right. So, there's, as you can tell, there's lots of different considerations and potential complications of genetic testing. So genetic counselors are a tool. I mean, I am a genetic counselor, so I might be a little bit biased, but we can be a tool for patients who have questions about genetic testing and want some help with getting it started and knowing what test might be right for them. So we just wanted to walk you through what a visit with a genetic counselor might look like. So the first thing that we do typically with patients is collect personal and family history. And this can be a really great tool to let us know what might be in your family that would be relevant for genetic testing, who might be the best person to have testing or start testing in a family. And if we do have a result that comes back, who else in the family might want to consider genetic testing after that result is reported back. Next slide. So once we go over the personal and family history, a genetic counselor or provider experienced with genetic testing can help patients decide on what decision is or genetic test is right for them. So this might be testing based on what diseases we see in the family history, deciding what diseases they might be interested in learning about, what diseases they might not be interested in learning about through testing, and then deciding, if this is the right time for a person to go through genetic testing. So we really just try to guide patients through this process and help them make the decision that's right for them. Next slide. So once a patient has made the decision to move forward with genetic testing and we've gone through all of those considerations, the genetic counselor can then help coordinate genetic testing. So this might mean getting a blood draw, bringing the patient to phlebotomy, or even in COVID times, we've been able to actually send sample collection kits to patients' homes, and they can actually do the sample collection right at home. A genetic counselor can also help patients navigate the financial considerations of genetic testing to make sure that no one's paying too much for the testing, and can also help patients get resources to help cover the testing if necessary. And then finally, once testing has been done, the results come back. And as we mentioned, it can be a little bit confusing to interpret that on your own. So a genetic counselor or experienced provider can help explain those results and support patients as they understand how they impact their health. And they can also help patients talk to their family members if a result means that other family members might need to go through this process as well. Right, passing back to Dr. Hull.
Sorry, I couldn't find my mute. So in terms of resources, I think that we're going to put some of these in the chat, but as our senior population, one area where you all have a lot of potential power and influence for your families is to provide them with information about your family health history. And so certain conditions that may run in the family. And so the My Family Health Portrait is a tool to help collect and organize family history. And that can be used by providers to try to see if there are any conditions where things tend to run in the family and use that to help coordinate care. The Jackson Laboratory out of Bar Harbor, Maine, also has an excellent patient and family webpage. The National Cancer Institute has information about hereditary cancer risk, as well as genome.gov has a patient page. And then here at MGH, we have one of our genetic counselors, Deanna Brockman, led putting together a genetics and genomics web page that helps to link all of the many different subspecialty resources in genetics and genomics at MGH. As you know, it's a large system with a lot of expertise, but sometimes it can be hard to figure out, where the best place for your question might be. And so I do want to just kind of end with a note about how all of you can be a resource to others. So as I mentioned before, if you have kind of the knowledge about kind of your family health history, you might want to consider sharing that with your family members. And so a first step might be to write out your biological or blood-related relatives, to document any health problems in your relatives and the age when they were diagnosed, like cancer, heart issues, mental illness, birth defects, or anything that seems to run in the family. And then you can use tools. My Family Health Portrait is an example, or just kind of track it on your own and share this information with your healthcare providers. And remember, our family health history changes over time. And so that may need to be updated from time to time, as that will continue to grow your knowledge about your family's health. So we'd just like to say thank you to the MGH Preventive Genomics team, who have collaborated together for the past 2 years on a lot of these resources. And that's the end.
Thank you so much. So let's move on to Ms. Sindora.
Okay, great. Hi, good afternoon, everybody. My name is Sindora Puluru, and I'm one of the geriatric nurse practitioners at the Mass General Geriatric Medicine Clinic. I'm going to be giving a few updates regarding our clinic and some general updates as well. The first update is related to our new name. We are now Mass General Geriatric Medicine, and we are no longer using our previous name, Senior Health. We've also moved to a new location. It's been a few months, but some of our patients have not seen us yet in the new building. So we wanted to just make sure everyone is aware that we have moved to Yawkey Building, which is part of the main hospital, second floor, Suite 2C. We have found that there are many benefits with this move. For example, the Yawkey Building has its own parking garage. There's also X-ray and other radiology services available in the same building. And the first floor has a coffee shop and a cafeteria. So there are a few perks to this move. And the second update I have is related to the flu vaccinations. Since all of our patients in the clinic are 65 years or above, you are eligible for and should be receiving the high dose flu vaccine known as Fluzone, unless you've had a history of allergic reactions. The easiest way to receive a flu vaccine is at your local pharmacy. And we're also offering the vaccine in the clinic. If you have an in-person visit, you can get the vaccine in the clinic. However, we are not hosting a flu clinic this year. Another option is Mass General Hospital has a central flu clinic that is located at 165 Cambridge Street, also known as Charles River Plaza, on the second floor. They have walk-in appointments available, and the flu clinic will run until December 10th. We are going to provide the link in the chat function regarding the hours of operation for the flu clinic, as well as how to schedule an appointment through Patient Gateway if you're interested. And then the third update is regarding the Pfizer COVID-19 booster shots. As you may already know, the Center for Disease Control and Prevention has authorized the Pfizer vaccine booster doses for eligible populations, including everyone 65 years and older who have completed the original series, the initial series for the Pfizer vaccine, as long as it's been 6 months or greater since the initial series. We do recommend that all of our patients who have received the initial Pfizer vaccine series receive their booster shot if it's been 6 months. And Mass General Hospital is offering limited appointments for the Pfizer booster for our patients. And there will be a link provided in the chat function for the MGB website so that you can schedule an appointment if you're interested. However, the easiest way again is probably through your local pharmacy. Many sites, including CVS and Walgreens, are offering free Pfizer vaccine booster shots. Other options are to search for vaccine options by going to vaccines.gov or mass.gov to find a location near you. And then I also just wanted to let you know that the Department of Public Health is also offering in-home COVID-19 vaccinations, either the initial series or the booster, and we will provide the phone number for the in-home option as well in the chat function. Also, most of you may have seen that the FDA released an update yesterday evening regarding booster shots for Moderna and the J&J COVID-19 vaccines in eligible populations. We are still waiting for formal guidance from the CDC and the hospital, and we do anticipate that the additional guidance will be coming very shortly, but at this time we don't have formal guidance, so we're all still waiting as well to hear from the CDC and the hospital. And updates will be shared via Patient Gateway and email. All right, so I'm going to hand it over to my colleague Haley, who will be discussing a few more clinic-related updates.
Hi, good afternoon. So as Sindora mentioned, I'm Haley. I am one of the other nurse practitioners at Mass General Geriatric Medicine, and I have a few updates pertaining to our clinic, and it is very nice to see some familiar faces on here. So the first is about virtual visits, and at present, telemedicine or virtual video visits can only be done if a patient is currently in Massachusetts at the time of the visit. Since the public health emergency has been lifted, the state and federal laws only allow these visits if you're currently in Massachusetts. The next is about Patient Gateway. So please only use this messaging portal for non-urgent communication. We want to remind people that it's not monitored over the weekend or after hours. And sometimes it can take up to 24 to 48 hours for a response. So if there is an urgent concern, we recommend that you contact our on-call provider if it's after hours, or call our office, during the day. So during the non-business hours, we always have an on-call provider who's available to be paged. And to get in touch with them, you would call our phone number, Mass General Geriatric Medicine, and that phone number will be listed in the chat. And there should be a prompt on the voicemail to page the on-call provider. Alternatively, you could call the Mass General main phone number to speak with an operator and ask to have your PCP paged, and that will be forwarded to the coverage. If you don't get a call back in 30 to 45 minutes, please, feel free to call again. And lastly, it's just our lab results protocol. So doctor or nurse practitioner interpretations of your results could be communicated to you by phone, letter, Patient Gateway, or during an office visit. It may take a number of days or even weeks for your provider to review and interpret your results. So we do ask that you allow up to 2 weeks before contacting the provider regarding your results. If there are any urgent or critical results, we want to reassure you that we will absolutely reach out to you as soon as possible in a timely fashion. So that is all I had, and I want to pass it back to Susan.
Thank you. Thanks to our speakers. All of you gave incredibly important information. And one, excuse me, I just really want to put in a plug for everybody completing the family medical history form. Just a quick story from my own personal experience. I have 35 first cousins, and I am one of the oldest and the one that is most in touch with most of my other cousins. And I probably get a phone call or an email once or twice a week wanting to know, did so-and-so have this? How did Granny die? Etc. Was so-and-so adopted? Do we need to worry about them? And fortunately, my mother loved sort of keeping track of all of our family history. So I learned a lot, but I just think it's invaluable. And it's so important for your grandchildren as well. And especially as people begin to start thinking about having children, they really want this information. So I just really encourage everybody to do your family and your descendants a favor by completing those family medical history forms and making sure they're somewhere where people know how to access them. So the first question that we got today was about the National Precision Medicine NIH funded initiative called All of Us. that is a program designed to develop a national precision medicine biobank. And so I'm going to put this question to Dr. Hull. What do you think about all of us?
Well, I'm currently a participant and using the data. And I got my blood drawn after they started taking people back a few weeks ago. And I told the research coordinator that I'm currently actively using some of the initial data that's being released, actually looking at self-reported family health histories. And they said, you're the first person to tell us that so far. So, but I think actually, you know, I will probably be biased, but, you know, I think it's an exciting opportunity. The All of Us research program, there are many biobanks kind of across the world that have been started to try to better understand the interaction between genes and health. Many of these biobanks have been in European countries or have really mostly recruited individuals of European ancestry. And so one of the focuses of the All of Us research program is to actively recruit individuals who have traditionally been underrepresented in biomedical research. So that doesn't only mean racial and ethnic diversity. They're also actively trying to recruit gender and sexual minorities, as well as individuals from lower socioeconomic status backgrounds. And so it's exciting in that way because a lot of these groups have been left out of research, or not necessarily intentionally, but because of how recruitment strategies have gone in the past. And so I think that there's a lot of learning to be done there about our genes, environment, and health. You know, in terms of the participant perspective, I actually, part of my goals in enrolling were to understand a little bit more as a participant what the consent process was like. And so there is an e-consent process where they take you through kind of the goals of the program with videos and with a knowledge check. And then there is the option when you, if you donate a biospecimen, so blood or saliva and urine, to opt in if you'd like the program to return genetic test results. These are research results. They would need to be clinically verified, and you'd have to talk with a clinician about them, but and they won't be everything. They would just be for specific disorders where we know you could potentially do something about them. But there is an option to opt in to receive that information. And so this is kind of a novel way of going about. It's a research project, but there is a goal to return results to patients over time.
Yeah, and I would just add, I certainly agree with everything Dr. Hull just said. And I was actually on the initial grant team for our health system and was very involved in the engagement. And I think it's a very important program because of the effort to include all of us, not just the people that have traditionally been included in this kind of biobank. And you do get, someone put in the chat, if you enroll, you get a $25 gift card. And the other thing I also want to mention is that our health system also has a biobank that you can enroll in. And Dr. Hull, I don't know if you want to say anything about that. You're on mute.
I'm sorry about that. So biobank enrollment, yes, I think that, you know, there are a ton of research opportunities out there. And, you know, I think that with different biobanks, there are different, from a research perspective, you know, the thing that's special about the MGB biobank is we can, because it's linked to the electronic health record and you can get a little bit more in-depth information from the data there, you can potentially have some richer data. And so, I think that there are a lot of research opportunities, but it's always really up to the participant to think about, is this something that, is right for me? And that's why we have consent processes in place. And, I do think that this type of, these initiatives are going to continue to grow. Dr. Russell and I both came from the VA, where the Million Veteran Program was ongoing. And so that's another large cohort of patients. But I do think that over time, we're just going to have more and more. And
Yeah.
One thing I just, go ahead.
Go ahead. Go ahead.
I just wanted to add, because I do get some questions about this in clinic, about the return of results from these biobanks from all of us. I just wanted to add, if you do have a family history or personal history where it's been recommended that you have genetic testing, it's probably best, in order to get it done in a timely manner, to ask about your doctor about a referral to a genetics clinic, because while these programs can return these results, it's done on a research basis, which can be pretty slow and not always in a manner that can actually be helpful for your healthcare immediately. So if you want actual actionable results, it's best to just inquire about that with a genetics professional as well.
Yeah, I would agree with that. And I'm going to pose a question, and I'm not sure who's the best to answer this, but I think it's very important. And that is, if you want to get genetic testing, do you need a physician referral? And how does insurance cover this?
Renee, do you want to take that?
Sure,
or
yeah.
Talk a little bit about some of the options?
Yeah, so there certainly are cases where you might need a referral for an actual appointment, and that would be usually based on your insurance program. So we always encourage people to, like any other specialty visit, just to check before scheduling an appointment. In terms of genetic testing, that can vary also based on the actual cost of testing can vary based on a person's individual healthcare plan. I noticed someone said Medicare does not cover preventive genetic testing. So while if you were to check with Medicare, usually the case is going to say, they're going to say, no, we don't cover this. But I will say that a lot of specific genetics groups are plugged into various resources that can help get genetic testing covered. And a lot of labs are actually providing just genetic testing free of charge for folks with Medicare or Medicaid. So while Medicare and Medicaid might say that they won't cover it, genetic testing labs might waive the fee. So it's worthwhile to just ask a provider about the exact testing that's needed, and they might have some resources that that can actually cover the testing for you.
Can you say a little bit about which types of genetic testing may be most likely to be covered in the fashion you just described?
Yeah, so some examples might be, as Dr. Hall mentioned before, there's certain criteria that people might meet for hereditary cancer genetic testing, for example. And so in those cases, if you meet very strict criteria for that, that might be kind of more likely for your testing to be covered. For cases where, like that familial hypercholesterolemia, there might be, if you have a cholesterol level above a certain number, that might qualify some folks for testing coverage. But like I said, sometimes even with those criteria, a specific lab might have a sponsored program in order to allow better access to testing. So even if you don't meet specific criteria set by some of those task forces, there are sometimes ways that we can get around it.
Okay. All right. And this is a question, I'm not sure who to pose this to. So Dr. Russell, I'm looking at you. And it's a question about, someone posted that they got their booster at our new healthcare center that's affiliated with the North End Waterfront practice. And that some of the pharmacies, such as CVS, say they are not able to administer follow-up Pfizer jabs. And I just noticed at my local CVS that they had a big sign that said they only have Moderna. So I don't know whether it's related to that or if anybody has any more information about that, that you might be able to share.
Yeah, I mean, as I've said in many meetings around this, we're finding out these things at the same time as our patients. There's not really a lag time. So my general understanding is that there's studies underway around mixing and matching the various vaccines, but we don't have any definitive guidance from the hospital of how to advise our patients. I do know that, I had to get my third booster because I had to, I was 8 months out, and I didn't have a problem at the time. So I'm just wondering if it's actually a particular supply chain issue for that pharmacy.
Yeah.
Because my understanding of there's not really a log jam in general on the vaccine availability anymore.
Well, for what it's worth, I just got my booster at a Wegmans, and just literally walked in and said, "Do you have any?" And they said, "Yes." So I said,
Yeah.
"I'm here." We do have another comment, but I think it's worth saying something about, and that is any perspectives on 23andMe and the kind of information you get from the sort of for-profit genetic testing companies.
Well, I think to kind of build off also the last question in terms of coverage. So you can really divide a lot of these tests into health risk tests. Many of those are these direct to consumer options. And the direct to consumer market, which includes 23andMe, has really changed a little bit, evolved, shall we say. So 23andMe might be kind of the original model of, I'd like to find out some things about certain health risks. They use a specific methodology where they only test for very specific changes in the genetic code. So they're not reading kind of the genetic code completely for each gene like they do when they do sequencing. And so, it may be that it's not completely comprehensive compared to some other options out there, but you can basically go online and you can order it, and that's it. There are some newer models that are emerging with some companies where they'll have actually kind of a physician team hired by the laboratory that can kind of sign off on your genetic testing. Again, these are usually health risk panels. And so these are not, these are for patients who are curious, but not necessarily somebody who has symptoms of a condition. For those individuals, we'd encourage coordinating that with your clinical team, or at least sharing those results with your clinical team, so that they know kind of what you're getting outside. Anything else to add?
Yeah, I mean, I agree. I think 23andMe can be a fun tool, but even on their reports and on their website, it's not meant to be used for medical care. So while they do have health information, any information that comes back really should be confirmed in a clinical lab. And the biggest concern we have is that, as Dr. Hull was saying, was actually a false negative because it isn't comprehensive. So one good example is the BRCA1 and 2 genes. They actually only look for 3 genetic changes out of thousands that could come back if we were to do a test that, like the ones that we actually run in clinic. So if someone comes back with a negative from the 23andMe resulting, it's reassuring, but there could be many other things that are being missed by the test. So it's not necessarily the most appropriate test for that purpose.
Okay, thank you. Thank you. We are almost out of time. I'm just going to see if there are any other questions. I just will say that there are many things that I feel fortunate about that we have at MGH, but I think Dr. Hull and Ms. Pelletier's expertise is invaluable, and because this is a whole new realm of medicine, if you will. And I think the more that we learn about this and the more that we have these resources available to our physicians, and our primary care practices, the better off we are in the long run. So thank you for all the work that you're doing. But I just want to see if Dr. Russell or anybody else has anything to add in our closing couple of minutes.
I don't think I have anything to add. We're working on do we know next month's topic yet, or are we still meeting to discuss that?
I don't think we know it, but I actually have an idea that we can
Okay,
discuss.
good.
But
I just feel like we need a cliffhanger, a teaser to just say, so we'll have another interesting session next month, and we'll try and do it not on Halloween, not on Thanksgiving. I'm sure that staying awake after turkey to hear our talks, probably not so easy. So
I don't want to compete with sports.
right, exactly.
I would compliment that and add also that if any of you have specific topics that you'd like to hear experts speak on, please email myself or Matt or Susan or Monique, any of us. And I just double that this was really interesting information, and thank you all. But other things, back to Susan.
Yes, I think we have one new, one just quick thing just to put out there as a potential topic. We are also very fortunate at Mass General that we have members on our faculty that sit on the U.S. Preventive Task Force that makes decisions about screening, clinical recommendations. And one of the most recent ones that has come out that I think has generated a lot of questions is about the use of baby aspirin. And so, you know, when I'm getting questions about that, I know it's generating a lot of questions. So I just want to say that it might be fun to hear something about the work that committee does, how they make their decisions, and how they make their recommendations, and whether we can actually trust them or not, because I think that's a very important issue, and what the process is they use. So, but there are many other things that we could share with you. So let us know if you have other things you're interested in. And enjoy this beautiful day.